Good afternoon. I'm Dr. Vinay Dheer, and today we will be discussing a novel method that we have been evaluating for mediastinal and GE Junction EUS. In our last video, we discussed how a sagittal view helps us negotiate the cricopharynx and allows us to look for lymph nodes, mediastinal lymph nodes, station 2 to 6. This is a continuation of the same thing where we will use sagittal EUS to look for lymph nodes at station 7, 8, 9, and also look at the GE junction in a sagittal view. The purpose behind this exercise is that the existing methods, very good though they are, concentrate on issues which are probably not of very great importance to us gastroenterologists. In my opinion, a referral to us for EUS is only made for a few reasons. One is looking for a intra-esophageal submucosal lesion, and two is to look for an extra-esophageal lesion, and of course to biopsy either of these. Um, in practice, what we have been taught about doing EUS traditionally here is oriented mostly on the heart, on the aorta, and on the trachea. These are important landmarks, no doubt, for us to guide our way through the esophagus. But what is most important is the wall of the esophagus. So if we are using a linear esophagus, a linear EUS scope, you will be seeing only one wall at a time. And what we are taught is how to look at the IVC, the left atrium, the left ventricle, the aortic outflow tract, and the pulmonary artery. I personally do not feel that information is really required for us. It is more for the cardiologists to look at these structures. What we are interested in, how is the wall of the esophagus? It is normal, it is abnormal. And are there any lesions within the wall? And secondly, are there any lymph nodes or other lesions outside of the esophagus in the mediastinum? So for that, a sagittal view is likely to give us more information. Now, how do you obtain sagittal view? It is very easy. You have to just tilt your scope downwards and then rotate clockwise and anti-clockwise until you see a tubular esophagus. It's not one wall. You will be seeing two walls parallel to each other, a tubular esophagus. Then you gently negotiate the tube, looking at all the wall layers till you reach the GE junction. Once you are in the GE junction, you will need a little more maneuvering, look towards the direction of the fundus, and gently go forward, looking at the wall structures. So once we have done that, we are pretty confident of not missing any lesion because we are seeing at two layers of the esophagus parallel to each other. It's a tubular view. Now let me show you some example of how we do it. So this is, I'm going down from the carina, and you can see there are two layers here. See this? So this is the esophagus. We are in the esophagus. You can see the muscularis propria. And now here you see this is the diaphragm. So above is the esophagus. Below is the fundus. This is the diaphragm. So this is a nice view of where exactly the GE junction is. Now, you can do the same thing from below also. In this case, we are coming from the stomach upwards. Again, as I told you, you have to do tip down and rotate clockwise and anti-clockwise till you see a tubular lumen. See here? Here we are seeing a tubular lumen with air. And then if you can see all the wall layers from mucosa till the serosa here. Once you have obtained this view, and I'm labeling the other side also just to show you that where is the lumen, and we have obtained a sagittal view here. And this, of course, is the fundus. Once you obtain this, you slowly start withdrawing. To the right extreme, we are seeing a faint view of the diaphragm. We will like to confirm it. So again, the same thing, tip down, rotate your scope clockwise, counterclockwise until you get a tubular view. And you see this is the diaphragm. See this? This is thick muscle that is coming across is the diaphragm. And you will see the nice curve of the GE junction. So this is exactly how you see in a CT scan. Esophagus here, G junction coming, curving down, and fundus. So this gives us a very good idea of the two walls of the esophagus, and anything that is outside the walls can also be picked up. So like this, gently withdraw and keep looking at the layers at every position, and you are unlikely to miss any lesion here. I find this method very fast. Once you have understood how to get this view, it's a very fast scanning of the esophagus and the GE junction. So this is the diaphragm here again. You can see the heart here. On the other side, to the left, you will see the aorta. So it's a little reverse view. So this is the heart here. You can see the esophagus. You can see the pleural deflection. Here, the heart is coming. And gently we are withdrawing to see if there is anything in the mediastinal area, periesophageal area. And you know, here in this case, there is nothing like that. Again, I am introducing to carefully see the wall layers and going towards the GE junction. And you can see you have a beautiful view. If you want to be more clear, you can introduce 2 to 3 cc's of water in the lumen, so you can identify the lumen. But I don't usually do it. Most of the cases, you can identify the lumen by the air that is there inside. So this view, I continue till I am at the GE junction. And then coming back, I continue till I see the subcarinal nodes. See here, these are the subcarinal nodes. So this gives us a good idea of the lower esophagus, G junction, and then station 7, 8, and 9 lymph nodes if they are there. See here, this is a station 7 lymph node, which we are seeing a subcarinal lymph node. So it's a little different from how we do EUS. Now here, in this case, there were lots of lymph nodes, and we will see all of them. So this is the fundus. See here, this is the diaphragm. You can see the diaphragm very well, liver below, and you're already seeing a lymph node here. This is station 9. Just above the diaphragm, station 9 lymph node. Then I turn and get a tubular view. See, I'm withdrawing it very quickly and looking at section 7, 8, and 9. So you see, this is a station 7, huge lymph node here, or a lymph node conglomerate. So here what you are seeing is, you are seeing esophagus like how you see it on the CT scan or on the MRI, and you are seeing the periesophageal structure. See, there are lymph nodes on the other side also. You will not miss them. This is the trachea. As you know, I continue to withdraw, and you are seeing more lymph nodes. These are the station 4 lymph nodes. You can see paratracheal and station 4B. Last time I showed you how to see station 4, 5, and 6. So please refer to that video if you have to see. As I continue to come back, we are now almost coming to the cervical esophagus, and there are still lots of lymph nodes. Keep rotating your scope, and you will see lots of lymph nodes here. So this is station 4A. I last time showed you how we divide these lymph nodes. What are these various stations? Please look at the previous video. As I'm continuing to withdraw, there are many, many more lymph nodes. This is station 2A. So here you will see the prominent arteries of the neck being displayed. The thyroid will be seen. See, this is the thyroid. and you will see the subclavian vein and the carotid artery. So here is the thyroid, lots of lymph nodes in this case. This is the sternocleidomastoid. So I find doing this sagittal EUS very, very useful in my practice. It's pretty fast, pretty efficient, and I don't miss intraluminal or extraluminal lesions. I do not have to rotate my echoendoscope because the traditional teaching is every 2 centimeters rotate it 180-degree clockwise and then 180-degree anti-clockwise, so that you are seeing both the walls, the around 360 degrees. Probably we do not need that with this method. Try practicing it, and I am sure you will enjoy it. Thank you.